Hello, how's it going? I'm Dr. Emenari. I'm one of the orthopedic surgeons here at OrthoVirginia at the Westchester office. I'm coming to you guys today to give a talk about how to decide of where to do surgery. So the talk is, where should I do my joint replacement? Should I do it at a surgery center, standalone surgery center, or a hospital? We'll go through a little bit of different things that are to consider about that and also we'll discuss some of the literature out there that kind of supports one thing or another. Just to kind of start, I wanted to introduce myself. I've been in the Richmond area now. I just started my third year at OrthoVirginia. I did my training, my study engineering. I did a medical degree at Howard University. Afterwards, I did my surgical training in orthopedics 5 years at the University of Maryland in Baltimore. And so my family and I were mainly from the DC, Maryland area. Afterwards, I wanted to do a little bit more training and specialize in revision, joint replacements, as well as primary and robotics. I went to the University of Chicago for a year and get a fellowship there. And then after that, I've been here in the Midlothian, Johnson Willis area serving patients at Johnson Willis Hospital, St. Francis, and also at our surgery centers. So the outline of our talk today is just to kind of briefly go over joint replacements and kind of just talk about some of the prevailing topics as far as conservative treatment, as well as what timing or when do you start considering surgery. And then we'll talk about changes in healthcare that happened over the last 5 or 6 years. So it's kind of led to a large amount of patients going to the outpatient surgery center. I'll talk about the surgery center, some of the similarities between the outpatient surgery center as well as the hospital. And then I'll go into reasons why one person should consider one or the other. So just as a brief overview, so treatment of arthritis conditions, we most of the time treat this conservatively, meaning that even though you may have varying degrees of arthritis in your knees or your hips, you don't have to run and get surgery for it, even if it's severe. Namely, we would start with physical exercises, home exercises, even sometimes going as far as acupuncture, dry needling. Also, we will use medications, anti-inflammatory, creams, or Tylenol to try to help control the pain and the symptoms from the pain. But I always tell everyone the main treatment for arthritis is to try to make your bones or try to make your joints stronger and try to maintain or get more motion. Sometimes weight loss can be helpful. Every pound of weight that you lose is 3 to 5 pounds of pressure off your joints. Also, sometimes for severe knee arthritis, using a brace can be helpful to provide more support. It doesn't always lead to you not having instability of your knee, but sometimes it can also provide a mental support system to let you know you have something to help block or help guide your motion as you move around. When you run through all the conservative treatment options and you exhaust all the options, that's when you start considering surgery. When I start talking to people about hip and knee replacement surgery, I try to make sure I go through all these options with them and I offer them different things that they can do. Conservatively, usually when I decide to schedule a patient for surgery, it's because they come into my clinic and tell me that, Dr. Emenari, I'm having severe pain in my hip or my knee, and it's affecting how I want to live my life. I can't do the things I like to do. I can't go on cruises. I can't travel. I can't go to weddings because I'm always worried about how am I going to get around on my hip or my knee. At that point, that's when I start discussing with patients with surgical options. Yeah, excellent. So this is just a picture of what a hip replacement and a knee replacement looks like. So if you look at the image to the left, you can see in the first image that patient has pretty severe arthritis of their knee. And so even though we call it a replacement, it's really a resurfacing. So we're getting rid of a bad surface and we're placing a prosthesis or an implant in that has a better surface. It's almost like we're treading a tire. Nowadays, these replacements can last up to 25 to 30 years. And a lot of that has to do with some of the innovations in the last 10 years with the different components used in the knee. So back when I first started my training, we used to tell patients that they needed to wait until they were 60, 65 before considering replacements. Nowadays, people are getting replacements younger and they're actually doing very well. And those replacements should last an extended period of time. Looking at the image on the right, that's just another example of a hip replacement. Once again, you're replacing that ball and socket joint. And so whatever is diseased, that's what we try to replace. Now, I wanted to talk about some of the significant changes over the last, I would say, 6 to 8 years that has kind of led to an increase in how many people are getting outpatient joints. So the first thing is COVID-19. So 5, 6 years ago, at the beginning of COVID-19, a lot of patients, a lot of hospitals, a lot of doctors still wanted to do elective surgery, but didn't want to do it in the hospital setting. So we were moving a lot of patients from that setting to the surgery center. Even patients now don't want to go to the hospital to get surgery because they're worried about infections or they're worried about catching transmittable diseases. And so that led to a big uptick in patients starting to move their cases or starting to have surgery at the outpatient surgery center. Another thing, you can go on to next. Another thing was that the Center of Medicare and Medicaid back in 2017 actually changed the coding for a total knee replacement and made that coding now acceptable in the outpatient setting, which once again told doctors and physicians that you are getting the approval to treat those patients with that insurance in the outpatient setting. And all the other insurances kind of followed that. 2 years later, they also came and did the same thing for the coding for the total hips. And so that basically took total hip and knee replacements out of the inpatient hospital stay where patients had to be admitted to the hospital and stay at least 2 nights, where now the patient can either go to a surgery center and go home that same day, or they can go to the hospital and be only in the hospital 1 night and be discharged after less than a day stay in the hospital. So that had a dramatic effect to kind of shift things over once again to patients getting surgery and going home sooner. Another thing that had an effect here is that back about 10 years ago, 25% of patients after joint replacements were needing a transfusion. There's been a lot of literature and a lot of studies showing that transfusions can increase your risk of having a periprosthetic infection. There's been a lot of advancements with different types of medications, one being called a tranexamic acid, which actually has decreased the rates of transfusions, where now we're rarely giving transfusions to patients, once again opening the door for people to get surgery in different places and not worrying about having complications afterwards. And the last thing I think was probably the most important thing was pain control. And so we're now approaching pain with what we call a multimodal approach, meaning that we're not just throwing narcotics at the problem and hoping that you'll get better with that. We're giving you Tylenol, we're giving you ibuprofen, we're giving you Celebrex, we're giving you Flexeril, we're giving you sometimes even nerve pain medication like Lyrica or gabapentin. We're hitting pain from 5 different directions and also with narcotics in order to decrease a patient's dependence upon narcotics. It decreases the risk of people getting addicted to it, and also it allows us to hit pain from there in many different directions to allow patients to do better. Also, when patients get surgery, we work very closely with our anesthesia partners, and we also sometimes do blocks, regional blocks, especially in knee replacements that can help with pain control. And also for some surgeries, both the total knee and total hip replacements, sometimes we can do spinal, which once again decreases the risk of the patients having an effect from anesthesia medications. And so it's been a lot of changes over the years. I've been in practice for 3 years, and when I started my training, we used to have patients in the hospital after joint replacement for at least 5 to 7 days. And then we used to write them a script for a lot of narcotic medications. And since I started my training several years ago, the pendulum has swung completely over to kind of getting patients in and out the hospital. And we have a better idea of how to control their pain. All right, so there's been a lot of studies published. You can kind of click through on this slide. There's been a lot of studies published talking about the impact of outpatient joint replacements, also talking about the cost savings from joint replacements with patients going to surgery centers. So there's been a lot of studies stating that for patients, it's very safe for them to go to the outpatient surgery center. And so what I wanted to kind of get to the point of this talk was, it's not only safe to go to the outpatient surgery center, but there's reasons for consideration of both options. Go on to the next slide. So some of the similarities between the outpatient surgery center and the hospital is that, once again, you can still go home the same day from both locations. I think the process might be a little bit more streamlined at the surgery center since that's the main option available to patients, but I still do outpatient surgeries at the hospital and patients go home the same day. Also, a 23-hour stay in the hospital after a joint replacement is still considered an outpatient surgery. Moreover, the complication rates for both they're having surgery at a surgery center or at the hospital are relatively the same, less than 1%. Pain control, as I said earlier, we're all doing multimodal pain management, and that's kind of the same for both patients in both settings. Also, the risk of other complications dealing with transfusions, and also technology is available at both locations. Just for an example, at Johnston Willis Hospital, at St. Francis, and also at our surgery center here, we have the Mako technology, which is a robotic assisted surgery. So you can go to any of these locations and still get that same advancement in technology if that's something that you're looking for. And also overall, the outcomes after surgery are getting better and better. And so regardless of where you go, patients that go to the outpatient surgery center or the hospital, both of them still do pretty well. Now, some of the differences, starting with the surgery centers, that obviously if you are having surgery there and you are not being admitted to the hospital, the overall bundle of costs of the patient is less. There are some insurance companies nowadays looking at a patient's medical history, and they're sometimes saying that the patient will be cleared to have surgery at a surgery center instead of at the hospital. That's not happening a lot, but I've seen that happen a few times, and sometimes that's due to the fact that the overall cost of the insurance and the deductible the patient has to pay is less because the cost of the whole care is less at the surgery center. There has been signs showing that there's lower risk for infection. And where that comes from is that in the hospital, even though a lot of orthopedic practices have a specialty unit where there's usually clean and abortive infections, you're still around patients on other floors that may be sick from different type of diseases. And so you have providers walking in from one room to the next, or one hallway to the next. Sometimes you can have infections being transmitted unknowingly from just simple things as people not taking the time to wash their hands, or to make sure that when they're entering a room with infection, they don't go see someone else that has no infection. So sometimes it can spread that way, but overall, an infection after a surgery is a lot less, but it's harder to control the outside factors at the hospital. After surgery at the surgery center, we get people up and moving right away. So early mobilization, we get them up right after surgery, and then we get them up and moving up and down the steps, and then get them on their way. And they usually start therapy within a couple of days after surgery. So the outcomes are really good. And also, it's a much less stressful environment since everyone that's going through that pathway is going through the same pathway. Now, at the hospital, there are benefits at the hospital. Sometimes I do surgery there and the patient believe or think that they want to go home, and then after surgery, they may feel like their pain is a little bit too much, or they don't feel as comfortable as they once thought they felt, and so they want to stay overnight. And so when you go to the hospital, that option is always available. Sometimes I like to have patients have somebody home with them after surgery for a week. I've had some individuals that are a little bit on the older side, and they may not have a lot of help at home, or their husband or wife may not be strong enough to help them up if they weren't able to get up from the commode. And so they stay in the hospital maybe a couple days longer, or sometimes they may even go to acute rehab after surgery. But that happens on a very rare occasion. Also, like at Johnston Willis, we have a specialized orthopedic unit. And so the nurses, the physical therapists, the case manager, all of them are used to treating orthopedic patients. And so it makes it much easier for the patient to kind of get through the therapy session and also have everything lined up for them to go home. And as a fellowship trained joint surgeon, I do a fair share of revisions and also infections. And so I can manage these things at the hospital where I have infectious disease, I have pulmonology, I have the ICU, I have everything possibly available to me if I need it in those settings. And also sometimes there are people that need surgery, but they may have a complex medical history. And so doing them at the hospital allows me to have access once again to all the medical professionals if I need them to kind of weigh in on a problem or issue. And so there are benefits to do surgery in the hospital setting, and there's benefits to do it at the ambulatory setting. And I feel as though patients have to talk it over with their provider physician to figure out what's best for them. And so just going through the postoperative care is kind of the same for both avenues, regardless of where you go. Most of us like our patients to start physical therapy right away. Sometimes you may start with home therapy, a home occupational therapist, and a home nurse, or you may start right away with outpatient physical therapy. Once again, we still treat patients the same and try to control pain and decrease the use of narcotics after surgery. We get people up and moving. For clot prevention after surgery, I provide my patients usually with aspirin, 81 milligrams twice a week. For hip replacements, I do that for a month. And for knee replacements, I do that for about 6 weeks. And then you have close follow-up with your orthopedic team. My team, I see my patients in the hospital. Usually after surgery, I come really early in the morning and see them to try to make sure I see them before they see therapy, to try to see how they did overnight. And then when they do go home, I see them at 2 weeks after surgery to check the incision to make sure everything's okay. And then again, I see them 6 weeks after surgery just to make sure they're progressing well with therapy. So you get close follow-up with the team just to make sure that every step of the way that everything is going well. I do any revisions or more complex cases, I see them a little bit more often just to make sure if any problems arises, I can able to address it sooner. So, but that being said, the last slide. The question everyone always asks is, where should I have it? And I talk to people about this daily. It's very much multifactorial. It very much depends on how comfortable you are with going home that same day, how motivated patients are to have therapy and get up and start moving with them. Also pain control, how much can you tolerate and what kind of medications you would need, and also your history. So your medical history, meaning that patients with history of like chronic kidney disease or that are on dialysis, that have AFib or history of heart attacks or strokes, they can still have surgery, but they may need to get it done at the hospital setting just to make sure if a problem arises that we're able to address it. And so it's not a very clear-cut answer, but I think that you talk these things over with your provider and you're able to find out a solution or a pathway plan that works for you. I see a question here that says, what is too old for a joint replacement? I don't necessarily look at age when I look at joint replacement. There are individuals that are 60 years old that may live in a nursing home, and there are individuals that are 60 that are still running marathons. And so I look at a patient's physiological state, meaning that I look at how active they are, how much they're doing in their community, how much are they going to the gym, and how they feel. I've operated on patients electively for joint replacements up into their late 80s. And so age is important, but for the most part, I try to look at every patient individual and see how they are outside of the age, how physically active they are. I had a patient recently that said to me, like, she was in her late 70s and she's like, I'm getting a little bit too old. If I get to 80, that means you won't do my surgery. And I looked at her and I told her, it's like, as long as you stay active and you're highly motivated and you're still in the same physical state, I don't see any reason why we couldn't do surgery if you're healthy enough to get it. But I will say this though, based off the literature, patients that are 80 years old and older, that is an independent risk factor to have a complication after surgery. Like I said, the risk for a complication is low, it's less than 1%, but that is something to consider.
I just said thank you so much and wanted to let people know we will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will answer as many as we have time for. So our next question is recovery time age related?
I think to a certain degree, the older you are, sometimes the older it is, the harder it is to bounce back after surgery. But I look at patients and I see how well they do with therapy and exercises before surgery. And once again, like I said earlier, I go by the physiological state, not so much the age. Obviously, there is a difference between somebody that's 60 and somebody that's 85. But there's some people that are higher up in age that you would never know how old they are unless they told you. And so I go by how active patients are, and I take everyone at the point where they're at. I don't compare them to anyone else. I look at people and say, as long as you're making incremental improvements through therapy and through your progress, I think you're making good progress.
Thank you. Do you prefer in-home PT or outside PT, at least at the start?
It sometimes for that as well is case by case. Personally, I prefer outpatient physical therapy. I think that outpatient therapy aggressively gets after you in order to get you up and moving, especially in knee replacements. After you do a knee replacement, you get your motion in that first 6 weeks after surgery. And so I like to be aggressive and try to get them moving as much as possible. I think with home therapy, sometimes it's variable depending on the therapist that you get. There are some that is really good. There are some that are not they don't push the client or patient as hard. And I've seen both ways. So personally, I think that I have a better expectation of what I'm going to see when a patient goes to outpatient therapy as opposed to home. But I still have patients start at home if they're not able to get transportation to therapy early on, or if it's just more convenient for them, or if therapy is really far away from their home, I'll start them on home therapy first for about the first 2 to 3 weeks before transitioning to outpatient.
Thank you. Can you have full anesthesia in the surgery center?
Yeah, so you get general anesthesia in the surgery center, and they still do a block. The goal is to get you up and moving out the surgery. So in the surgery center setting, we don't do spinals. A spinal can last up to 6 to 8 hours after surgery where you can't move your legs, and that is not very good if you're in a surgery center. So we do general anesthesia for almost all the outpatient surgeries so that you can get up and start moving immediately after surgery.
Thank you. Do you prescribe the continuous motion machine or the ice machine after surgery?
I like the ice machine, the ice maker machine. I think it provides very good pain relief. The CPM, or the continual passive range of motion machine, has gone out of favor maybe over the last 10 years. I think when I started my training, they used to have that attached to every bed, and we found out that that actually doesn't increase your motion after surgery. So there are some people that still ask about it, but there's been a lot of literature behind that showing that for that extra cost of renting that machine, it's not going to give you that extra degree of motion. So currently, we don't really prescribe that or recommend that.
Thank you. Is there a preference for or against robotic-assisted surgery?
I think every surgeon has their own preference. I do both robotic-assisted and I do unassisted surgeries. I think that robotic surgery makes the surgeon more reproducible, meaning that if you don't do a lot of surgeries, if you're doing one every couple of weeks, it makes you make sure that you can keep that same standard every time you do it. I do a fair amount of the surgeries with the robots and without it. It doesn't make a difference in the patients that I treat. I always tell everyone that I try to give them a joint replacement specific for them. Robotic surgery allows me to look at their alignment, look at the numbers, and I can kind of make sure whatever I'm putting in them fits them correctly. But I'll always want to make sure I say this: there is no difference in outcomes after surgery, whether you get a robot or not. So there's a bunch of surgeons that don't use it. There's a bunch of surgeons that do. You will still do fine whatever that surgeon feels comfortable doing.
Thank you. Are all prosthetic implants the same?
They're all slightly different. So there's several different companies that you can use, or most surgery use, for implant choice. Some of that is due to the preference of the company, because I know what this company offers me and I like the options available to me there. Some of them is because I like the representative from that company and I trust them when I'm in the OR that they're going to give me good advice if I'm running into any issues. But overall, across the board, there's no difference between the implants. We may like something more than something else, and I have some implants that I like more. You do a lot of revisions, and so if I'm doing the primary, I like to be able to revise it easily if I need to, but there's no difference across the board between any of them.
What questions should you ask your surgeon before surgery? And how do you tell if the surgeon is experienced?
I would say you should ask your surgeon for a timeline of how your treatment plan will go. You should ask them what to expect after surgery, like a real honest, realistic expectation. You should also ask them about the risk and benefits of surgery and when things go wrong, will they still be there to handle it or whether they have to send it to someone else. I think there's important questions to ask because when you put your trust in someone to do your surgery, I think it's important to know if everything goes perfectly, everyone's happy. But if things don't go the way you want to make sure you know those things that could happen beforehand. Also, I would say you want to always ask them, like, what can you do beforehand or before surgery to put yourself in the best position possible? And how can you tell your surgeon's experience? I get that question a lot. Oftentimes, I'm 37 years old, so a lot of patients say, you've only been doing this for a couple of years. How do I know that you have the experience to do it? It's hard to say. As surgeons like me that are fellowship trained, I do a fair amount of revisions. I do a fair amount of the trauma cases that come into our hospital. But I would say that you can look at the surgeon's reviews, or if you can talk to anybody that may have had surgery with them, that will be helpful as well. Also, something I would state is that any of the surgeons here at OrthoVirginia, we go through a strong vetting process to even be hired to this company. And so most of the surgeons here, or most of all of us here, are experienced in what we do. And even if we are not entirely sure about a certain thing, we have a very broad network of who we can reach out to try to make sure that we're doing the right thing, or we can have someone in our OR. Sometimes if you're not comfortable with doing the surgery, the complex primary revision, we have a network where you can send that patient to one of your partners that feels more comfortable doing it. And I'll say personally for me, I do a fair amount of revisions in complex cases. And so I get a lot of referrals from our partners to kind of handle some issues. So Experience can come in years, but also experience can come in the kind of training you have. And I think it's important just to be honest and ask them. I don't think anyone will feel offended or anything like that.
So you've mentioned revision several times. What do you mean when you say revision?
I mean, revisions is when joint replacement doesn't go right for a myriad of reasons. One of the most common reasons is infection. So if something gets infected, it's less than a 1% risk of that. But if it gets infected, it has to be addressed. So when I say revisions, I mean just redoing something or trying to fix an issue. I see a lot of people in the hospital that may have fallen at home and they've had replacements done years ago. So they may have broken their bone around the replacement. So you need to revise it or refix the bone. And so it's just basically any surgery after the patient has already had a primary replacement where something has to be changed or fixed. It doesn't always mean that something bad happened. It just means that sometimes these prostheses don't always last forever. And so we have to adjust things. But revision just simply means it needs a redo of any sort or of any type or reason.
Thank you. Can a patient with cancer have a joint replacement?
They can, but they would need clearance from their surgical oncologist, and they would need clearance from the hematology oncologist, and also sometimes they may need to get done at the outpatient at the hospital setting. It very much also depends on what kind of cancer they have and whether they're in readmission, also physically how strong they are. They can get surgery, but I would say that most patients that have cancer or have been treated for it, we would have to in with the oncologist just to make sure that they're safe and that we know what our risks are going into surgery. But anything like I think I brought up earlier, people with dialysis or chronic kidney disease, history of strokes and heart attacks, people are eligible to get surgery, just making sure you do due diligence beforehand to make sure you optimize the patient as best you can for surgery and do it in an environment where if a problem arises, you can address it right away.
Thank you. How long does the operation itself take for a knee replacement or a hip replacement?
I'll say on average about an hour to an hour and a half. It takes a little bit of time to get you prepped and set up on the table, and then to do the replacement, usually around that time frame. And then after that is usually closure, and then you're coming off the table. Most patients spend a total time of maybe 2 hours in the OR, and that's basically getting into the room, whether it be the anesthesia puts you to sleep in the room or they did a spinal outside the room. It's getting you ready on the table for the surgery, doing the surgery, and then getting you off the table and bringing you out the OR. I would say total time from in to out should be around an hour and a half to 2 hours.
When you're having hip replacement surgery, how does the surgeon know that the replacement will work with the other hip? The person who asked that was worried about wobbling when they walked.
Well, with the hip replacement surgery, I always ask everyone before I do this surgery, do they feel like one leg is longer or shorter than the other? Sometimes when you have arthritis in the hip, they can actually shorten your length, so you can feel like you're walking a little bit off kilter or uneven. When we're doing hip surgery from the front, we have x-ray while we're doing the surgery to make sure we can bring the hip back to either the level it was at before or try to match it to the other side to make sure you have two even sides you're walking on. Also, if I'm going from posterior during the surgery, when I put in all the trial prosthesis, I physically measure the length of your legs to make sure they come off the same length. So we do a lot of things in surgery just to make sure that your hip joint works well or your knee joint works well. Moreover, we try to make sure that everything is stable, and then we also spend a lot of attention looking at length to make sure we don't over lengthen you or shorten you. And so I ask those questions beforehand just to make sure that I'm on the same page with the patient, whether I need to bring up their leg a little bit or whether I need to bring it back to the same area.
Thank you. Are there ways of reducing the scars as you're doing surgery?
Ways of reducing the scars, I would say that as compared to surgery maybe 10 to 15 years ago, our incisions are a lot smaller. And that's in part due to a lot of us are practicing minimally invasive techniques, and also the implants and the jigs and gauges we use during surgery also allow us to use small incisions. I use a small incision for my hips and so I don't think that there's many scars, but we try to use a smaller scar profile. Also, when we close the knee, I think we try to make it a very aesthetically pleasing closure because that's all the patient sees. And so oftentimes I try to make sure that we close things well and close things. But as far as the incision is concerned, I use just as much as I need for the surgery. But it's not multiple scars, usually just one scar unless you're having robotic surgeries. You may have small little incisions in other places in order to attach like trackers to connect to the robot. But outside of that, most of us practice like minimally invasive techniques.
Are braces used after knee replacement surgery the way they're used after ACL surgery?
Generally not, because we try not to limit motion. Like I said, after a knee replacement, I'm able to get you full range of motion in the operating room. And those first 6 weeks, your body is healing the scar tissue. And so I try to prevent anything from limiting you from getting your motion and working with therapy. I sometimes use braces after I do a complex revision surgery to provide the patient with more support. If I'm worried about them getting up and moving on this leg, I want to make sure everything is stable. But usually after a primary knee replacement, we don't put any braces on your knee unless there was some outside reason we had to do that. But usually we try to make sure you can get up and start moving immediately without any hindrance with therapy.
Thank you so much, Emenari. We appreciate you answering the questions. Would you like to close?
Close your eyes. I would say that it's been an honor and privilege to give you guys this talk. I hope it provided some insight in where you can have your surgery done and reasons why you can have it there. All of us joint surgeons or just surgeons in general that do hip and joint replacements, we're more than happy to talk to you about the benefits of either location and what works best for you. I would just say there are questions you should ask your physician before moving forward with surgery, and just make sure that you feel comfortable with where you're having surgery and you feel comfortable in your recovery.